Now I invite myself to present the next case. Yeah. Yeah. Yes, sir. Yeah. So this is something that has, to the best of my knowledge, this topic has not been spoken of or written about till now. So I am hazarding a topic. So yesterday, during the presentation on interpretation of VNG, there was there was something that was pointed out by the delegates, and that was that in the lateral canal BPPV that I was presenting, and I wanted everybody to concentrate on the horizontal nystagmus. Dr. Vishal and some of people actually pointed out, oh, in addition to the horizontal, there is some amount of vertical component. And at that time, I made a prayer and request, please spare me at this point of time. We can, because that was more to drive home a point as to how we can study what is happening in the inner ear. Let us ignore some things, is what I had told at that time. Now we do see this kind of findings where in the horizontal canal what is expected is only pure lateral nystagmus, but then once in a while you start seeing this a mild upbeating component or a downbeating component, and then where to place this. That one thing is known, that semicircular canal and otoliths interact with one another, and one of the main functions of this interaction of otolith and semicircular canal, where the semicircular canal helps in the otolith, is in resolving the conflict between tilt and translation. What is that tilt and translation resolution is, when you look at the otolith organ, if this is my utricular hair cells, if I tilt to one side, all the hair cells sag because of the gravity to this side. Fine. That is because of a tilt. Now, in the same utricle, if I am moving, translating to my left, then also because of the inertia, these things will go to this side, which means both for rightward tilt and leftward translation, the neural information provided by the utricle is the same. So the utricle itself cannot tell the brain whether at that particular time it is a tilt or a translation, and the brain uses signals coming from the semicircular canal simultaneously to resolve this conflict. That is one part, semicircular canal helping. There are other things also like the timing signals and all those things. I will not get into that. But the main point here is that there is an interaction between the utricle and semicircular canal, where the semicircular canal helps the otolithic input in putting it into perspective. The other interaction that has been studied very well is where the otolith's organ and their ability to detect the line of gravity helps to make sure that the semicircular canal input is aligned to the line of gravity. So even if a little bit of head tilt to one side and you do a rotation, the eyes move according to the earth horizontal rather than the head horizontal, so that they are aligned to the gravity vertical, appropriate to gravity vertical. This is the thing where the otolith organ helps the semicircular canal. So these kind of interactions are known. Now, the problem was these patients with horizontal semicircular canal showing some amount of vertical component. Why does it happen? Now, the question that came into my mind at that time is, can we simulate a nystagmus and then lie down in the right lateral and the left lateral position and then do this study? So, can I use a caloric test to do this? For caloric test, what has been told is, okay, if I sleep on the right side versus, if I sleep on the left side, if the caloric nystagmus is actually produced because of a convection current, then the convection current will reverse. So it may not be useful. So what we had to do, whether it is actually convection or not, we needed to look at it. See, what we have been told is convection is where heating up makes the fluid start moving upwards. The hot water goes up, the cold comes down. So that is what happens in convection. But convection also means the hot ones are the lighter ones, so it goes up. The cold water is the heavier water, so it comes down. So that is how the convection works. If convection is the way in which caloric nystagmus is produced, then convection related caloric nystagmus should not be produced in space or in parabolic flight, this kind of situations where there is no effective gravity acting. But European Space Lab experiments held in 1983, where they did the caloric test in space, clearly proved not just that caloric nystagmus exists in space, it was there, not just that, even the intensity matched that is seen in the on Earth. Okay, so they had to come up with alternative explanations. For us, more than getting into the alternative explanations, here the most important thing here is, it is not convection, so we don't have to bother. So I can use this to study why this particular kind of upbeat nystagmus is seen in lateral, what is meant to be lateral on the, in the lateral canal BPPV. So what I did is, I made myself a subject. Okay, I made myself a subject, and then I got cold caloric stimulation to my right side. If right side is cold caloric stimulation, what you expect is a left beating nystagmus according to cows. So we start getting a left beating nystagmus. And here, when I am lying down supine with the head a little bit up, 30 degrees up, as it is recommended for the caloric test, we get a left beating nystagmus, and there is absolutely no vertical nystagmus seen there. Now what I do, I turn to the right side. The moment I turn to the right side, I mean, there is a left beating nystagmus. In addition to the left beating nystagmus, you start seeing a mild, what do you see there? Look at the black lines and purple line and tell me what nystagmus you see? Downbeat nystagmus. The red line and blue line is telling that it is a left beating. So in addition to the left beating nystagmus, you start seeing a downbeat nystagmus. Now I turn to the left side. When I turn to the left side, what you get here is an upbeating nystagmus. I started getting an upbeating nystagmus. If it was convection current and the convection currents are reversing the direction of flow, then the left beating should also have gone reversed. That is not got reversed. The left is continuing to be left, but the vertical on one side was turning to be down, and the vertical on the other side is turning out to be upbeating to the left. Now, this is what has happened in the caloric stimulation. So we can think, okay, it is caloric stimulation, maybe there is something else happening, the kind of flows happening in the other canals could be the factor, so all these things. So what we thought, okay, we will take one patient of benign paroxysmal positional vertigo of the lateral canal, and in which position, lateral canal BPPV patient, in which position, if the person gets, here you see left beating nystagmus on the left lateral position. If there is a left beating nystagmus in the left lateral position, that if that is associated with a upbeating nystagmus, what I am thinking could be right. So what we did, let us take a patient who is getting a left beating horizontal nystagmus, who is proven lateral canal, who was cured by only by a lateral canal maneuver, that is a Guffoni maneuver. We took that particular patient's thing to study. What you see here, this is a left beating nystagmus, and in this the patient is actually lying to the left lateral side, just like how I was lying to the left lateral side during my caloric stimulation. And you see what? Vertical trajectory is upbeating nystagmus. And in the same person, if the person was having right beating nystagmus and the person was sleeping to the right, again the vertical should show upbeating. We saw this right beating on the right lateral, again it is showing upbeating. I am not making any lofty claims here or anything. This is one topic where we have not yet started discussing or started thinking the way in which the semicircular canal-otolith interaction could be altering the actual observed trajectory of nystagmus, that it need not always be only semicircular canal. Once in a while, little bit of deviation probably could be explained by this one. So this is not to make any dogmatic claims, nothing, just to open our eyes and start thinking in these lines, because till now when it comes to BPPV and the way BPPV nystagmus trajectory is altered by position has not been studied or published till now. So I thought I'll make myself a subject and make this, and what we have done, I thought of making a presentation. Thank you all. Yes, sir. Yes, sir. Yes, sir. Yes, sir. No, we can take all. Yes, sir. Yes, sir. We have the videos. We have the videos. I will share the videos. I will share the. Same. There is a vertical component. Yes. There is a vertical component. Yes, sir.
What I'm trying to say is...
What is the use?
No.
Okay, sir.
Usefulness or uselessness is all retrospective.
Yes, sir.
What is the kind of thought
Yes, sir.
this should generate
Yeah.
in our minds
Yes, sir.
vis-a-vis the findings that you are getting?
Generally, what happens is when you start seeing a small amount of upbeat nystagmus as it happen, it sometimes passes our mind like, are we missing something? Is it multi-canal? Or is it, am I missing a central diagnosis? This kind of things happen. So if we all put our minds together and start picking up these patterns and then start noticing them, like yesterday we were alert and then people told there is an upbeat nystagmus, and then I stopped at that time to discuss. So when we see this and we see this consistent pattern, like if it's a right beating nystagmus and the right lateral, you see some amount of upbeat component, then it makes us less anxious when we see this kind of patients, and we will not be bothered, okay, it could be central because I am seeing this. It is the fear of the unknown will be removed and we become more relaxed.
No, that's one part.
Yes, sir.
But doesn't that also force us to think, shouldn't we be thinking of the fact that we are totally neglecting the saccule and the utricle?
Yes.
As
Yes.
far as vertigo is concerned.
Exactly.
It's suddenly, I mean, we are, as if we are with horse blinkers on, blinders on,
Yes.
that any vertigo
Yeah.
is the property of the three semicircular
Yes.
canal,
Yes,
the
sir.
utricle and saccule be damned.
Yes, sir. So we should start thinking in those lines. In fact, that we are thinking of 3 semicircular canals itself is a significant progress. 8 years ago when I started, I was only thinking of posterior semicircular canal.
Okay.
Okay, and when I first started 8 years ago, okay, for those people who are just beginning, okay, let me reassure you, the first time I made a Dick-Salpike maneuver, that was around 10 years ago, I did a Dick-Salpike test and got a positive response. Positive response is I don't even know what nystagmus, what it is. The patient had nystagmus and vertigo on right Dick-Salpike testing. I did not know whether the person's EPLI should be done on the right or the left. Then I told the patient, you go back home, you come tomorrow, you need 1 day rest for us to do this particular test, but the rest for me to read up and come back again.
I wish that happens with everyone, because
yes,
then we can reach the heights that you've reached.
No, sir. So it happened. So from posterior canal, we started looking at 3 canals. From 3 canals, we started looking at canal pairs. This itself is a significant progress. Now, what you are inviting us is to take from the canals onwards to start including the otoliths also, and their heaviness, their lightness, and all those things, and then we start seeing much more, and more of our patients get benefited. Okay. May I request Dr. Balakrishnan and Dr. Alfargal to summarize the proceedings of this particular session on positional vertigo. Yes, sir. You can come on stage, sir. Sir?
Can I have one question, sir?
Yeah. All questions are there. Dr. Alfargal is there, I am there, Dr. Balakrishnan is there. Yes, ma'am.
Yeah, it's to Vishal, sir. Actually...
Vishal, sir, please come on stage, sir.
So, I could appreciate that explanation of eye movement while doing positional maneuver, the vertical movement as well as horizontal movement, because it is a 2-dimensional thing. So while explaining the torsional component for the vertical canal, how will you explain it with the movement of endolimb? I could satisfy myself with, because posterior canal has got a connection with the superior oblique of same side, and the anterior canal has got a connection to the inferior oblique of the opposite side. So functions are intorsion and extorsion. So I could satisfy myself that way. So do we have any ways of explaining how torsional component is coming? Can you correlate with the endolimb movement?
Yeah, honestly, I can't answer that question. Maybe Dr. Alpha.
What is the question?
I can tell one thing only, because there are vestibulo-ocular reflexes for every movement. So for torsional movement also, the vestibular pathway, semicircular canal activation happens, and that's how it stimulates those particular two muscles. But what happens with endolimb movement? Maybe
It is the same. It is the torsional component. It is because of the oblique muscles stimulation or inhibition. But from each side, each canal in each side, there will be specific this oblique muscle. So that's why it comes a torsional component beating toward the affected canal. It's the endolymph flow will stimulate both the recti muscle, the rectus muscle, and the oblique muscle. So the rectus muscle is responsible for the vertical component, and the oblique muscle is responsible for the torsional component. And the way the extraocular muscles pair to the semicircular canal make it, that is the activation of like posterior canal or anterior canal, makes it through the oblique muscle actions, that is the torsional components will be to the stimulated canal.
So I have a request to Cyclops groups. They should develop a model where we can see the position, all the semicircular canal on the both side, and we can see the different positioning maneuver. What will be the position of the canals? We can compare on the both side as well as the relation between the canals of the same side. And if possible, we can see the endolymph movement. It will be better for the beginners.
Actually, we started this work. Actually, we had one intern coming from the Czech Republic from Switzerland who was with us for 3 months, and she developed a complete MATLAB-based model. So we are playing around with it in the office. Once it becomes reliable, then we'll make it part of the balance eye. Thank you, ma'am.
I would.
Dr. Srinivas. Dr. Srinivas.
The torsional component in, with the vertical canals, it is the same extorsion and intorsion. It's different names for the same eye movements associated with this kind of positional vertigo. So what's written in some textbooks as intorsion or extorsion, it is the same, it's the torsional, it represents the torsional component.
There is already an app for this, whatever you are asking. Which there is an app already in the Apple phone, if you search for it, which shows the position of the semicircular canal, the debris. You can place it and you'll get the typical nystagmus. I share you the details of the app. It is already there.
And I think because of your question, I would like to tell one more pearl. Why we are getting this pure variety of nystagmus in central. What happens is, from the peripheral end organs, the impulses are coming together in the nerve. And from the nucleus, each of the vestibulo-ocular reflex pathway, for torsional it gets separated, the horizontal it gets separated, vertical it gets separated. So in patients with central lesions, if there is a lesion, it can specifically affect one pathway. That's why pure variety of nystagmus is common in central, and in peripheral it runs together. The impulses are running together. So that is one difference between pure variety and this one.
So actually we have an excellent session. Dr. Vishal, really, he gave an excellent presentation with very clear demonstration and in-depth understanding. And the next speakers will go to real cases which explains the basics or the scientific foundation he presented in his lectures. So after this session, we expect that all of you are familiar about the pathophysiology of the benign paroxysmal positional vertigo and the different varieties and the different types, the common types and the less common types, and how the pathophysiology is going on, and how the treatment maneuvers are based on understanding of the pathophysiology. So we expect that you will be comfortable in diagnosis of posterior canal, diagnosis of lateral canal, diagnosis of anterior canal, and we have agreement that anterior canal do exist. I know that some big names, they deny its existence, but those people who deny the anterior canal, if you look to their practice, they see the patient 8 months or 10 months after the initiation of symptoms. So we don't take their opinions seriously. Just I wanted to give a little observation of clinical use. Did you correlate the side of BPPV affection with the sleeping side or no? What's your Indian experience? Because in my experience, with a little question, it's very sensitive and specific. In more than 95% of the cases, I ask the patient how you sleep. So most of the people, they sleep on the right side. So usually the right side is the affected side and the symptomatic side. I have this it has very, very high correlation. One time I got a young lady with anterior canal BPPV. So just simply I asked her, how you sleep? She told me I sleep on my face. She sleep with her face down and on her face. So that's sleeping way or sleeping position. It has a role in the benign paroxysmal positional vertigo. It's always precipitation of the otoconia occurs more frequently on the sleeping side. In our experience, we have seen that all the patients with medical restriction, they cannot sleep on one side, like pacemaker on the left side, they have to sleep in the right. They did surgery in the right side and they only sleep on the left side. It's just 2 months of this restriction on the sleeping side, most of them, they develop BPPV. So simply, I ask the patient which side you sleep, and if my impression or the nystagmus shows that it is the opposite side, I will have a doubt. But if my interpretation for the nystagmus matching with the sleeping side, it's always I feel comfort to diagnose that side. Except for the traumatic, post-traumatic patients, any side or any side can be affected. Doctor, you want to ask something?
Yes, sir. Again, Dr. Srinivas.
Yes, sir.
Very, very stupid question.
Yeah. There is nothing stupid, sir. If it's a question, it's a question.
Right.
Yes, sir.
Now, whenever we consider vertigo,
Yes, sir.
again, we are only thinking mainly about the semicircular canals.
Yes, sir.
Let's keep that aside for a moment.
Yes, sir.
Now, let's take Meniere's disease.
Yes, sir.
Meniere's disease is mainly a disease of the cochlear,
Yes, sir.
right?
Yeah.
The hair cells have got nothing to do with balance.
Yes.
And yet, the patient experiences absolutely incapacitating vertigo.
Okay.
There's no after effect, there's no back effect
Yeah.
on either of the semicircular canals in Meniere's disease.
Sir,
And yet,
yeah. Yes,
let
sir.
me complete.
Yeah.
It could be there in the utricle or the saccule, but we have never considered the semicircular canals
Yeah.
in Meniere's disease.
No, but usually it's considered. And all the testing will show there is some affection. It's very clear. And even the post-mortem studies, even the imaging studies, dilatation of the semicircular canal has been reported clearly. The nystagmus, the horizontal nystagmus comes, it's always from the lateral canal. The caloric weakness, it comes from the lateral canal. So all the literature, no, it includes affection of the semicircular canal for sure. But the mechanism could be different. Could be because of the endolymphatic hydrops, could be because of the potassium intoxication, which is passing in all the spaces, which is finally the vestibule and the cochlear, they are connected in some way. So like if you have ionic intoxication or some problem in the ionic balance, it could spread from the anterior compartment to the posterior compartment or the opposite. So initially it was, they found more in the cochlear and more in the saccule, but also with more studies they reported that also the semicircular canals, it shows. For the hair cells affection, no, they reported, and they specifically reported that the vestibular type 2 hair cells are more affected than the type 1. But the actual mechanism of the disease is not exactly known.
Absolutely.
It could be through the ionic intoxication, it's channelopathy, it's because of some mix of the perilymph with the endolymph, because of the endolymphatic hydrops, but definitely affection of semicircular canals is well reported in the literature in Meniere's disease. And most of the spontaneous attacks comes because of involvement of the lateral canal or the semicircular canals in the disease process.
Thank you, sir.
I think we have to think like a rhinologist here. One airway, one both system affected. Same thing in Meniere's disease. It is we who classify it as cochlear and other things. Again, WEMP has proved that all the receptor can be stimulated, only the threshold varies. So I think we should just stop dividing it. We have to think everything as one continuum, and then from there we take it up.
Yeah. And when Dr. Manoj asks something, he has also a thought process associated with that. So I think he should also clarify what exactly he is also thinking beyond that.
So why don't we think the other way around
Yeah.
when we are thinking about the semicircular canals?
Okay.
And start thinking of the cochlea. Why aren't we keeping the cochlea in mind
Yeah.
when we are evaluating
Yeah.
vertigo,
Yeah.
which we are again
Yeah.
compartmentalizing as if originating only
Yeah.
from the semicircular
Yeah.
canal. This is what I wanted to finally come to.
Okay.
Can
Yeah.
the caloric test,
Yeah.
instead of being a stimulation of the lateral canal, be a stimulation of the cochlea through the round window?
Okay.
Can that be possible?
Instead of this, the WIMP is there.
Sorry?
Maybe I didn't get your question exactly, but can you just formulate the question one more time?
Like we said that Meniere's disease is a pan-compartmental disease.
Yes.
Correct?
Yes.
But when it comes to the other issues of vertigo, we tend to compartmentalize it only to the semicircular
Okay,
canals.
okay, good. I got your answer.
Why don't we keep the cochlea into consideration when we are thinking of the other causes of vertigo,
Yes.
including the caloric test? What is stopping the cochlea from being stimulated when the caloric stimulation is being given to the ear? We are, after all, giving it to the external ear.
Okay, the auditory pathway and vestibular pathway has been well studied. So, like when you do stimulation of, like caloric stimulation, it's well studied where is the pathway it goes. Definitely, maybe there is some interaction, some connection between the cochlear and the vestibular system, and some sort. Even in some reports, they consider the importance of hearing to maintain the balance, because hearing gives you some sort of spatial awareness and gives you a space reference plane. But exactly know the pathway and the animal studies, that is the activation of the semicircular canal afferents. Otolith afferents has well established vestibular pathway. They know where it goes. So like cochlear stimulation, it wasn't reported exactly that it has a clear contribution to the vestibular pathway. So from these animal studies or from the basic science studies, they know where is the afferent. When you stimulate the afferent or the afferent nerve fibers or the end organs, when you stimulate, you know which areas in the vestibular pathway or the brainstem or even the cerebral cortex is good activated. So this is well studied, and the contribution of the cochlea in the balance maintenance is not well clear.
That's what I'm saying, that we are not giving it, we are probably not giving it the due importance. That's about it. That is the point that I'm trying to make.
I think we should start thinking.
10 years ago, we thought there was one BPPV. Today, I come to know there are 27 types of...
It's correct, but...
What, 20 types, sorry.
One point of your question is important. Why we don't think a lot about the otolith vertigo, and why we don't give overweight or give enough significance to the otolith dysfunction. I tell you simply which is more important, the otolith or semicircular canal.
The otolith.
The otolith. Why? Simply because it is the basic. It is the first organ, end organ in the inner ear which develop first. Saccule is the mother of the cochlea. So saccule in the primitive species and in the phylogenetically development, saccule is the first organ to appear. Yeah. So that means it's the most important structure in this organ. Yeah. Otolith organs are the most important structures in the inner ear. Why? Because they do feel the gravity. And feeling the gravity is mandatory for life. Some fish species will die if you take out their otolith organs, simply because they don't know where is up and where is down.
Yeah.
So otolith functions are very basic. And because they are very, very basic, Almighty Allah created them with many backups. So if you look to, we have one utricle in the right, one saccule in the right, one utricle in left, one saccule in the left.
Yeah.
Come to the utricle in the right, it's a curved with some hair cells is feeling in both directions. So do a dual function with overlapping function. It doesn't feel in one plane, it feels in different planes because it's curved and it's like a sheet. If you go to the saccule, it does the same, it's curved, like 90 degree, it's curved. So it's a feel in different planes. And both the two organs are overlapped together. Both organs are overlapped together. So actually, one organ from the four can feel the gravity in different planes.
Yes,
but because of their importance, Almighty Allah give us three backups.
Yes, sir.
So failure, complete failure of otolith organs is almost a theoretical. Even they found that is with ototoxic medication, the otolith organs are commonly spared.
Yeah.
Because if the organ is phylogenetically started first, it will be more resistant to hazards and the disease processes.
Yes,
That's why even with ototoxicity, the otolith organs are the last to be affected. They have resistance, they have backup, they work with the pattern recognition, not like the semicircular canal. It got stimulated in a certain plane, in a certain way. No, they got stimulated with all the planes, they got stimulated in different ways.
Sir,